Welcome to Roadmap to Residency, Evidence-Based Application. This video is about respiratory pathology. Now, all the topics that we are going to touch in this video is in detail discussed in the respiratory modules. You can go and check that. And in this video, we will only be discussing a few questions targeting different important respiratory system pathology. So, which of the following underlying disease process is most likely present in this patient? So here we have a 56-year-old man who is being evaluated for dyspnea and chest discomfort. Medical history includes hypertension, type 2 diabetes mellitus, and chronic kidney disease. Temperature is 100 degree Fahrenheit, blood pressure is 160 upon 90, and pulse is 98. And respirations are 24 per minute. BMI is 31. The patient undergoes a two-part nuclear medicine test. During the first part, he breathes in radioactive pressure and a lung scan is performed. And in the second part of the test, he is given an intravenous injection of a different radioactive material while breathing the normal air. And the scan is repeated. When the images are compared, a large area of the lower right lung is not visualized in the second scan. Now, based on the observed findings, which of the following underlying disease is most likely present in this patient? Deep venous thrombosis, endobronchial spasm, left ventricular infarction, spontaneous pneumothorax, or viral pleuritis with effusion. Pause the video and think about the answer. So here you can see this is a normal ventilation where you can see there is a homogeneous distribution of the trace material. But we can see here in these areas, here, there is abnormal or unmatched perfusion in these areas. And this is a picture of multiple defects, but, but there can be even a single defect in most of the cases. And in most of the cases, there is only a single defect too. So this patient with dyspnea, chest discomfort, and a perfusion defect on ventilation perfusion scan likely has a pulmonary embolism. Now, PEs are most commonly caused by deep vein thrombosis in the lower extremities that subsequently embolizes to the pulmonary vasculature. Signs and symptoms include acute onset pleuritic chest pain, shortness of breath, tachycardia, and hypotension. CT pulmonary angiography is typically the imaging modality of choice. However, BYQ scans are helpful in evaluating the patients in whom angiography is contraindicated. Now, these BYQ scans are two-part studies that compare the regional ventilation and perfusion. The initial phase uses a radio level aerosol that is inhaled and delivered throughout the tracheobronchial tree, and the second phase uses an intravenous tracer that is distributed throughout the pulmonary vasculature. Now, the images are then overlaid for comparison. Normal results show even distribution of both radionuclide tracers throughout the lung, that is BYQ match. Now, BYQ mismatch means when the alveoli are ventilated but not perfused. And this pattern can be seen in diseases that increase the physiological dead space, including pulmonary embolism and malignancies that obstruct the arterial blood flow. Here we have one more question with us. So if a malignancy is diagnosed, it is most likely to be which of the following types? A 55-year-old woman comes to the office due to persistent cough, exhaustional dyspnea, and recent unintentional weight loss. She has no chronic medical problems and takes no medication regularly. She has never smoked and has no history of exposure to industrial pollutants. She works as an accountant at a large accounting firm. Now, her vital signs are normal. A physical examination reveals decreased breath sounds and dullness to percussion at the left lung base. Imaging studies shows an irregular mass in the lower lobe of the left lung and a left pleural effusion. A diagnostic thoracentesis is performed and the aspirated fluid is sent for cytological evaluation. Now, if a malignancy is diagnosed in this thoracentesis, it is most likely to be which of the following types? Adenocarcinoma, bronchial carcinoid, mesothelioma, small cell carcinoma, squamous cell carcinoma. So here you can see adenocarcinoma incidence is 40 to 50%. The location is peripherally. The clinical associations are mainly clubbing or hypertrophic osteoarthropathy. But the squamous cell carcinoma and the small cell carcinoma, they are centrally located, and also the large cell carcinoma, which is very rare, is peripherally located. Now, this non-smoking woman with cough and weight loss has a peripheral lung mass with an associated pleural effusion. This presentation is concerning for adenocarcinoma of the lung, the most common lung cancer in the general population, women and non-smokers. Although tobacco is the most significant risk factor, the etiology in non-smokers is thought to be multifactorial. It can be due to some environmental exposures of radon or secondhand smoking and any underlying lung disease. Now, let's talk about this question too. Which of the following is the most likely cause? A 64-year-old man is evaluated for worsening cough and shortness of breath. The patient has a history of hypertension and type 2 diabetes mellitus. He smokes a pack of cigarettes daily and drinks alcohol occasionally. Temperature is 100.4, blood pressure is 140/82, and pulse is 92. Lung auscultation reveals abnormal breath sounds. Chest X-ray is shown below. Which of the following is the most likely cause? Elevated pulmonary capillary hydrostatic pressure, exaggerated reactivity and inflammation of the airways, excessive fibroblast proliferation and extracellular matrix deposition, leakage of protein-rich fluid in the alveolar spaces, mucociliary hyperplasia, and inflammation in the large airways. So that question is all about pneumonia. Now let's summarize in brief the morphological stages of pneumonia. You know that there are four important morphological stages of lobar pneumonia. The first one is congestion, where there is increased cytokine-mediated permeability. We can see the bacteria in the exudates. There is red hepatization, where the lung appears to be red because of the fibrin deposition, because of the RBCs that invade the exudate. Then there is the gray deposition. Now, when these RBCs decrease in number and WBCs increase in number, then the lung becomes gray in color. That is called as gray hepatization. And finally, when the macrophages come and attack and they start eating the exudates and bacteria, and now the lung is resolving, that phase is called as resolution phase. So congestion, red hepatization, gray hepatization, and resolution. So this patient has cough, shortness of breath, fever, and right lower lobe infiltrate on chest X-ray, indicating lobar pneumonia, likely due to a community-acquired pathogen, Streptococcus pneumoniae. We have discussed about these stages in the previous figure. You can just pause the video and go through the explanations that is written in words here. Now, besides the lobar pneumonia, there are two other major morphological categories of pneumonia. Bronchopneumonia is an infection of the terminal bronchioles that results in patchy consolidation of a number of lobules. Interstitial pneumonia is an infection of the interstitial tissue of the lung with minimal or no alveolar infiltrate. Atypical pneumonias are often associated with an interstitial infiltrate. Now let's talk about the last question for this video. Which of the following histopathological changes is most commonly associated with the development of chronic obstructive pulmonary disease? A 65-year-old man with a history of heavy cigarette smoking presents to the pulmonology clinic with complaints of chronic cough, dyspnea, exhaustion, and recurrent respiratory infections over the past few years. Physical examination reveals barrel chest, prolonged expiratory phase, and decreased breath sounds bilaterally. Pulmonary function test shows airflow limitation that is not fully reversible with bronchodilators, with a reduced ratio of forced expiratory dissolved volume in 1 second, forced expiratory volume in 1 second to forced vital capacity. Now, arterial blood gas analysis demonstrates hypoxemia and hypercapnia, and chest X-ray shows hyperinflation. Now, these all are features of COPD, and now the question is asking us about the histopathological change seen in COPD. So, emphysema with destruction of alveolar walls, granulomatous inflammation with multinucleated giant cells, fibrosis of the bronchial walls, bronchial smooth muscle hypertrophy, or hyperplasia of mucociliary glands in the bronchi. So yeah, the correct answer is A, that is emphysema with destruction of alveolar walls. So COPD is progressive lung disease characterized by persistent airflow limitation that is not fully reversible. The most common histopathological change is emphysema, which involves the destruction of alveolar walls. In emphysema, there is enlargement of air spaces distal to the terminal bronchioles, leading to the destruction of alveolar walls and loss of elastic recoil. Now, this will result in decreased surface area for gas exchange and air trapping during expiration, contributing to airflow limitation. Thank you for watching. Keep studying hard.